when it comes to prostate cancer, there's a lot of work that's being done now in screening purposes. So you want to be able to find aggressive prostate cancers early on, but you also don't want to find the non-aggressive prostate cancers that lead to unnecessary treatment. And as we speak, PSA screening is being implemented in Sweden. And the PSA is a marker in the blood for the risk of having prostate cancer. So if you have a high PSA, then that would normally lead to performing an MRI or going straight to doing a biopsy. So what we did in this study was we compared different screening options for prostate cancer. So one of the options was that you took a PSA, and if the PSA was elevated, you did an MRI of the magnetic resonance imaging of your prostate. And then depending on what the MRI showed, if it showed a lesion, then you did a biopsy of that specific lesion. And you also did randomized biopsies of the entire prostate. But if it didn't show anything, then you wouldn't have to undergo the biopsy. So that was one strategy. And the other strategy, that was to use a new test called the Stockholm 3 test. And this new test, it has some different parameters to it. So it has clinical variables such as age, heredity for prostate cancer, etc. And then it also has genetic markers to it, and also some other PSA derivatives. So what you can do then with the test there, or what we thought we could do, is then you could use that instead of PSA to select which men you should do a biopsy in. So if you have an elevated Stockholm 3 test, then could you skip the MRI step and go straight to biopsy? Because MRI for the prostate is it has a lot of value, but it also has some issues with the availability, because you need a lot of expertise in, well, you need also a lot of equipment, but then you need expertise in, for example, radiologists looking at the scans. You need expertise in the urologist performing these targeted biopsies. So it's a step that it's sort of a bottleneck, the MRI step. And in this study, then we looked at these different strategies, and it was a randomized design. And basically what we found was that if you do the Stockholm 3 strategy without the MRI, you are able to find the same number of significant cancers. However, you do find quite a little bit more of the insignificant cancers, the ones that you don't want to find. So it comes a little bit with a price too. So it doesn't get you all the way there, but it's still quite a bit better than if you would only do the PSA followed by biopsies, which would be the other alternative if you didn't have the Stockholm 3 test. So basically, the conclusion is that in a setting where you have very limited access to MRI, you could use the Stockholm 3 test to find the same number of clinically significant prostate cancers. So basically, if you're in a region where you have a lack of MRI, then this could be an option, because we like to think it's a lot easier to send a blood sample than to send the patient for an MRI scan. So, for example, I mean, we're implementing the Stockholm 3 test right now in Norway, and they are sending the Stockholm 3 tests to a lab in a part of Sweden. So the logistics of it seem to work there. Yeah, so it already does that to a certain extent. If you compare it to just doing the PSA, the Stockholm 3 test has a better ability to find these more aggressive cancers compared to the non-aggressive cancers, but it doesn't get you all the way there though with the MRI. But there's another study that's been published by I think, so it was last year in Lancet Oncology. We showed that by using the Stockholm 3 test, you can also reduce the number of MRI scans that you need. So that compared a strategy where you would use the Stockholm 3 test to differentiate which of these patients do we send for the MRI scan. So you can use it for different purposes like that.